Good morning. My name is Sunjay Kumar. I'm a research resident at Thomas Jefferson University Hospital in Philadelphia. I'd like to thank SAGES for the opportunity to present our work on behalf of my co-authors today. We have no relevant disclosures. So in 1919, Dr. Cerezi published the first paper on the elective repair of hiatal hernias. And he was a passionate believer that every single hiatal hernia mandated surgical repair. But over the next century, the pendulum swung back and forth on this issue. Not everyone believed in repairing the minimally symptomatic or asymptomatic hiatal hernia, though some of the luminaries in the field, you can see this paper from Dr. Skinner and Dr. Belsey, some of the luminaries in the field did believe in repairing all these non-sliding type hiatal hernias out of fear of the complication of gastric volvulus. The SAGES guidelines for the management of hiatal hernia were published in 2013, and they note that routine repair of a completely asymptomatic paraesophageal may not be necessary, though they also acknowledge the weak evidence base for this question. This recommendation from SAGES was largely based on this decision analysis paper by Stellopoulos and colleagues. If I could summarize the paper in a really simple manner, I would say that they calculated the risks and benefits for both management strategies on the basis of, one, the risk of progressing to gastric volvulus, and two, how much worse outcomes are after emergent compared to elective repairs. The updated guidelines on hiatal hernia are currently up for public comment. I'm a co-author on these. Please take a look at them. But the new data similarly relies on 3 decision analysis papers that have similar structures. However, we'd like to propose a third variable that isn't necessarily accounted for in these models. How much worse is it to wait until the patient is older to perform an elective repair? We hypothesize that both elective and emergent outcomes in octogenarians would be worse than in senior age patients. To test this hypothesis, we use the Trinetics clinical database. This is a multi-center EHR-based network composed primarily of American academic institutions that provides de-identified data. We divided our cohorts into emergent and elective groups on the basis of diagnosis codes indicating obstruction or gangrene, as well as the timing of the operation relative to the addition of the diagnosis code. The octogenarian cohort was, of course, age 80 to 89, while the senior cohort was 65 to 79 at the time of the operation. Our primary outcomes are listed here. All of these were measured at 90 days. These were used to calculate absolute risk differences with 95% confidence intervals, and then we created a logistic regression model to calculate odds ratios, accounting for the variables listed at the bottom of the slide. So when we created our cohort, we initially started with 50,000 adult patients who underwent hiatal hernia repair during the study period. After applying our age criteria, we had 2,300 octogenarians and 15,000 seniors in the elective group, and 400 octogenarians and about 1,500 seniors in the emergent group. So we're gonna look at some demographic data quickly. The first column is, of course, the variable. Second column is octogenarians in the elective repair, then seniors in the elective repair. The last 2 columns are octogenarians and seniors in the emergent repair. As we can see, the cohorts are fairly balanced with regards to gender and race. With regards to the comorbidities within the elective repair arm, seniors had a greater proportion of overweight or obese patients, and then predictably in both groups, octogenarians had more hypertensive disease, ischemic heart disease, cerebrovascular disease, and percentage of patients with failure to thrive, and slightly lower nicotine or tobacco use. This is our data on surgical approach. I think that the most important thing that we can see here is that regardless of whether this is an elective or an emergent case, the vast majority are completed with a minimally invasive approach. And predictably, in the emergent cohort, there's a slightly greater portion of patients getting open approaches for their operation. Before I get to the results, I just want to talk really quickly about absolute versus relative comparisons, because I'm going to be speaking in terms of both. So in the United States, we frequently advertise 2% milk as having 43% less fat than whole milk, which sounds really impressive. But the 2% and 2% milk refers to the percentage that is milk fat, and in whole milk, that percentage is 3.5%, which gives us an absolute difference of 1.5%, which sounds a lot less impressive than saying 43% less fat. So getting back to our results, we're going to first look at the outcomes for the elective cohort. Again, variable in the first column, octogenarians, then seniors, and an absolute risk difference with a 95% confidence interval. If all three of the numbers are positive, that's a statistically significant result. If all three of the numbers were negative, that would be a statistically significant result. So first we see that octogenarians are at an increased risk of mortality, malnutrition, sepsis, respiratory failure, pneumonia, DVT, blood transfusion, and discharge to a nursing facility. When we look at our primary outcomes in the multivariate model, we see the same thing. They're at a meaningfully increased risk for mortality with an odds ratio of 3.9, respiratory failure with an odds ratio of 2.4, and sepsis with an odds ratio of 2.2. We'll look at the same thing now in our emergent cohort. So the octogenarians are again at increased risk of mortality, malnutrition, sepsis, and respiratory failure. And again, when we go to the multivariate model, we find a similar thing. The odds ratio for mortality is about 3.5, respiratory failure is 2.1, sepsis is 2.1 as well. So I think it's easy to look at these results and see something that confirms what you already expected to see. You may look at this and say, there's a much larger relative risk for mortality and meaningful complications, so we should offer more patients repair. Or you may look at this and say, this is a relatively small absolute increase in risk, and not every patient is going to cross over from watchful waiting into surgical repair. It's probably fine to pursue watchful waiting. I think that regardless, the data here does provide more information for an informed discussion with our patients in the office. The study had a number of limitations, including the inability to fully distinguish between age versus frailty, the likely inclusion of type 1 hiatal hernias, and an inability to distinguish what operation was performed for these patients. But in spite of these limitations, I still think that there's some useful conclusions to be drawn. One is the difference in mortality for the elective cohort is pronounced. When you talk about a 4.7% mortality, when we ask cardiology to risk stratify patients, 5% is considered high risk. This is very high risk for an elective procedure. And even setting aside mortality, even looking at other outcomes, these patients are very high risk for a challenging postoperative course. The other thing I'd like to point out is going back to those three models that I mentioned at the start of the paper. They relied on certain assumptions to make their calculations, and one of the assumptions in the Stellopoulos paper is that all emergent cases are done with an open approach. And they use that assumption to calculate the morbidity associated with an emergent hiatal hernia repair. But we see in our data, 85% of these are completed minimally invasively. Another assumption is the mortality rate. Across all three papers, they assume a mortality rate of 5.4 to 5.5% in emergent repairs. But our data in age 65 to 89 showed a mortality rate of just 3.9%. This opens up a lot of avenues for future study. It would be great to predict who's going to get gastric volvulus, who's going to develop worse symptoms later in life, distinguish frailty versus age further, and update the models with modern data. Thank you.